Hello to all of you, wherever you may be in the world. This is really a pleasure to announce that Africa PCR is back after the hiatus during COVID. And as part of our preparation for the 2023 edition, we will be running a series of webinars. The first of these webinars is tonight, this afternoon or morning, wherever you might be. And we're discussing a patient's journey in a STEMI scenario. And what we want to achieve by these webinars is to explore more than just the cardiological treatment of the patient, but to deal with the entire patient's journey from the initial presentation at a primary care center and final referral to definitive treatment at a tertiary hospital. And we will be helped with colleagues from Angola and Sudan for today's webinar. So the objectives of this webinar are to explore a patient journey from first medical contact to definitive STEMI treatment, as I've mentioned, to examine regional variation in infrastructure and systems of care. And we want you to bring your region into the discussion as well, not just Angola and Sudan. We want to hear from you wherever you might be through the discussion, the chat service. We also want to discuss how collaboration can improve STEMI treatment in Africa. And to do this, we've got our colleagues from the two countries. I'm the chairperson from South Africa, Johannesburg, and the University of Cape Town. We've got José Roberto dos Santos from Clínica Sagrada Esperanza in Luanda, Angola. We have Awad Mohammed from the University of Khartoum in Khartoum, Sudan. Ahmed Suleiman is from the same institution. He's your spokesperson. He will be taking your questions on the chat and bringing them into the discussion. We also have two colleagues from the primary care center in Luanda from Clínica Girasol, Antonio Sales Miguel and Isildo Dombele, who will be discussing their role in the patient management. So with that, I'd like to now move on to discuss this case and the first presentation in Luanda, and there is some discussion in Portuguese, which is translated by Roberto dos Santos and Antonio Sales Miguel.
Okay, good afternoon. We are here for the webinar of Africa PCR, how should we treat the STEMI, to show our reality. This patient was attended in Angola, in two hospitals in Angola. So I'm talking to my colleague, Antonio Sales Miguel, who was the doctor working the day that admitted the patient. This patient was admitted always stable. The diagnosis was made in the emergency department. The diagnosis was made with inferior myocardial infarction, ST, elevated myocardial infarction. He was admitted in the intensive care unit, always stable. Systolic blood pressure was 110 approximately. The diastolic blood pressure was approximately 75 to 80. So, and the heart rate was 45 per minute. Initially, we thought it was sinus rate.
Bem, a dor precordial já não era tão intensa como ela havia relatado quando começou com 48 horas, porque ela chega com 48 horas de evolução, sem fator aliviante, nem exacerbação, sem radiação também. Era uma dor de aperto, era muito moderada já a dor. Foi para UTI.
Okay. This is, she came, according to my colleague, she was at home for 48 hours. She came to the emergency department after feeling the pain, and she only came after 48 hours. She was saying at home the dose was very intense, but while she got in the hospital, the pain was not so intense. And then she came first to the emergency department, and then she was transferred to the intensive care unit.
Após a admissão na UTI, monitorizamos a paciente. Em termos de medicação, fizemos aspirina, 300 miligramas, e clopidogrel também 150 miligramas. E como não tínhamos o serviço a funcionar de hemodinâmica, então fizemos os contactos Foi nesse caso que a paciente depois, a posterior, foi transferida para a Clínica Sagrada Esperança. Então, o tempo todo que esteve na madrugada até de manhã, quando passei o caso com o Dr. Isildo, que me substituiu, a paciente sempre ficou estável.
Well, she was admitted, as I said before, with a diagnosis of inferior myocardial infarction. In the intensive care unit, she received clopidogrel, 300 milligrams, aspirin, 300 milligrams, and she was, during my shift that I worked with her during the night, she was always stable. And we called because we have a hemodynamic service, and it was not working. The machine was with a problem, so we couldn't do anything. We made the contact, and then we waited for the morning to transfer the patient. Você não tem trombolítico disponível?
Não, naquela altura não tínhamos também.
I did ask if you have lytic. At that time, they didn't have lytic available in the clinic. E durante a noite, ela não teve nenhuma arritmia, não teve taquiarritmia, não teve nada.
Não teve, manteve-se estável.
I did ask if during the night she had any instability or any arrhythmias, and then what my colleague says that she was always stable during the night. E houve necessidade de dar algum medicamento para dor ou não? Tipo morfina, não houve necessidade de dar medicamento?
Não houve necessidade de morfina, só foi o metamizol, né? Sódico, uma dipironazinha. E como o contacto já tinha sido feito com nossos hemodinamicistas, que tinham dito que o serviço não estava a funcionar, e que já estávamos a ver o contacto com a Indiama, então foi possível aguentar aí aquelas 4, 5, 6 horas durante a madrugada, e de manhã foi possível a transferência.
Okay, during the night she didn't need morphine. We gave metamizole, like a painkiller, but she didn't need morphine, and she didn't present any other instability. So we made the contacts because the lytic were not available. We made the contacts with the other clinic, Clínica Sagrada Esperança, and then in the morning we transferred the patient to the Clínica Sagrada Esperança. E queria saber se deste mais alguma medicação, para além do clopidogrel e da morfina.
Um oxigênio, catéter nasal, e foi observar mesmo o paciente. Estava tudo estável, não é? Já não apresentava aquela bradicardia sinusal, porque na urgência entrou com 45, depois foi na UTI já estava em 59, 60, e sem repercussão hemodinâmica, sem
Okay, we didn't give any other medication, only oxygen, clopidogrel, and aspirin. The heart rate was on the beginning was 45. After that, it was 52, 57. She was stable, no hemodynamic repercussions. So we just tried to transfer the patient early in the morning. That's what we did. Okay, muito obrigado. We are ready. Thank you very much for the cooperation, and everything is, we can know now everything about this patient. Muito obrigado, Antônio Salles Miguel, sim? Muito obrigado.
So thank you, colleagues, for that discussion on the initial case presentation and how the patient was managed. Awad, can you tell us about some of the circumstances in your environment, in your country, when a patient presents to a center where there's a non-functioning cath lab or there's no cath lab facilities, and the availability of therapies in your environment? Would you have treated this patient the same or different?
Yes, Farah, thank you very much for the opportunity, and thank you, Africa PCR. I'd like to thank you all for tuning in. This is a great educational platform, and let me jump into the answer straight away. Yes, as a very similar recurring theme here in Sudan. Of course, it depends where in Sudan the patient presented, but in many referral facilities, there would be no streptokinase available at the time. There is ECG and physician capable of diagnosing acute inferior myocardial infarction by virtue of ECG. But then what to do with the patient at that particular town or village, it depends. I did not catch where exactly in Angola that patient presented to have a similarity to where in Sudan, but in most of my country, streptokinase is the only available lytic agent. Is free if you present into a public hospital. It will cost about $15 if you present to a non-governmental hospital. Most of the patient, I would say around 60 to 70% would have received streptokinase if the patient presented within a reasonable time window. But the Achilles we're facing in everyday practice is the delay from the patient themselves. Like this lady already presented in a very good time to the local hospital, but in my country, this wouldn't have been the ideal time for presentation. They take a lot of pain before they present. Aspirin and Plavix, although not the original, the other brands of Plavix are available across the country. The patient would have received crushed aspirin maybe in the house. At least they know that much. But they wouldn't have recognized that as an acute MI to present early within the golden time for any type of treatment. If this lady was in my country, she would have received the same. I don't think she will be treated any differently at that particular point in time. Thank you.
Okay, so let's have a discussion and see if there's any differences in elsewhere on the continent, or have we got any comments, Ahmed, from the participants?
Yes, I think we're starting to get a good interaction here. We have a question about thrombolytic therapy. It's now 48 hours. Will it benefit the patient? And another comment on what was the ECG at initial presentation, now that the patient is 48 hours from pain onset. I think these are two good questions. What's the benefit of thrombolysis at this time? The patient has already 48 hours, and do we have any initial ECGs obtained earlier than this or no?
So we will show you the ECGs later in the presentation. We do have a picture of the ECG to show you, and Roberto will show you that when he discusses the arrival of the patient at his hospital. But I think let's discuss the question of late administration for thrombolysis, because this is a question that will arise many times with these late presentation. So, Roberto, do you want to comment on that point?
Yes, I'd like to comment because this patient, she's a nurse, and even among health professionals, sometimes the awareness is not there. People, they have chest pain, they work in a facility where they talk about myocardial infarctions a lot of time, but they stayed at home. So this brings a question to us that we still have to a lot of work to do. In my country, it is not everywhere that they have the lytic therapy. It's we started a program now in our network clinics for them to have the lytic therapy. But even sometimes in my own clinic, we do not have the lytics. I have one experience like 2 weeks ago. I told my colleague to give lytic to a patient that presented 18 hours after, and I was not around, and I told him, look, the best thing is to do, let's try the lytic, and we did the lytic. And in that case, we also will show it in March in Johannesburg in PCR. The result was very surprising. So 48 hours, no, it's not. I will not recommend to do it. But from 12, in this case, I did it like it was a shot by 18 hours. But 48 hours, I will not recommend to do any lytic therapy because. But I think we have to be sure with the patient exactly when the strongest pain started, because sometimes the pain didn't start the strongest pain didn't start already 48 hours ago. The pain may have a different fluctuant intensity. So my comment will be, we have to make sure when the strongest pain started and count the time from that scene after presentation into the hospital. But with 48 hours, I will not recommend to give any lytic therapy.
Yeah, that's interesting. You could have a stuttering presentation and then the total occlusion can come later. Actually, this is a worldwide problem of lack of awareness, not only in Africa. Many patients in sophisticated environments are presenting with thinking that they had indigestion for a long time. Awad, maybe you can comment on the situation of how who sees the patients first in most environments, and if it's a nurse or GP who's a non-cardiologist, what should they do with a STEMI patient? And then maybe you can comment on what educational initiatives we need to undertake to try and improve the awareness in the treating community, the doctors and nurses who first see patients.
Yeah, well, I think the fairest thing is to have the suspicion in this nurse or general practitioner that this might be a heart attack. At least they have to suspect this chest pain might be myocardial infarction. Then ECG is mandatory in each corner of the country. With this technology now of WhatsApp, we've been really getting a lot of referral, even from general physician, GP, that 3 to 4 times a day, an ECG will pop up in your phone that I have this patient somewhere down in the corner. I have nothing to do. This is the ECG. What do you think I should do? At least if you get to know the patient is having the problem, then you can get the ball rolling wherever that patient is. There is a lot of diversity in health facilities in the country, from poor small village to even big towns in my country where there is no facilities to do anything for a patient with acute myocardial infarction. But if we can spread the word around using whatever available means to educate not only our patients, but the doctors, our colleagues, that this is a time-sensitive emergency and you need to get the patient moving from that particular place. So I would answer your question that recognition of the problem is the first step. Then seeking help as soon as you know what the magnitude of the problem you're in.
So, Ahmed, any further questions from the participants?
Yes, we have many questions, but I think they might be better dealt with after the presentation by Dr. Santos, asking about DAP regimens, what kind of lysis are available, what happened to the patient, So maybe they're better dealt with after we hear the presentation from Dr. Dos Santos.
Okay. So what
I would like just, can I make a comment about the lytics in Africa? In my country, we have an issue about sometimes even you want to buy, but for those who sell lytics to the country, sometimes they're not available. And this is a big concern of us because when we wanted to buy lytics for our rural clinics, those ones who sell lytics, they didn't have it, and it took 3 months to have those lytics. So I don't know about South Africa, about Sudan, but for us sometimes it's difficult to have those people who sell the drugs, even for them to have the proper lytics, and it was streptokinase to buy, and took us like 3 to 4 months to get the drugs into the country. I don't know if the same thing happens in your country.
So I see that there was no availability of lytic in that clinic where the patient presented. Is that a common scenario?
In Angola, yes, it's a very common scenario that you don't have the lytics. We are struggling, so that could be not so common, but at this moment is very common, and the majority of the hospitals we do not have lytics. We made a program. We are running into it with the primary care hospitals and primary care physicians, but the scenario is very common that we don't have lytics available in majority of our hospitals.
Awad, what are you advising your primary care centers when they have a patient and they have lytic available? Who advises on the lytic? Do you tell them to give the lytic? Do they make a decision independently? Who oversees the process and the transfer?
Yeah, this is it's usually the local physician that make the call of whether to thrombolyze or not. Before that is usually some communication has to be made before that. Is although there's no official channel for it, but one of our colleagues, the cardiologist, would have somehow get to know that the patient is having a STEMI somewhere in the country. But usually the local physician, if the patient present to a town that is like a third level town in the country, they will have a physician. They're all around the country. Now we have emerging program of emergency physician, structured training for emergency physician in Sudan, and they have graduated about 6 batches already. Most of them are cluttered in the capital and in big cities, but now we're seeing wise decision, correct thrombolysis taking place in 3 or 4 big cities around the country. Still, the gap is there, and a lot of patients are presenting very late to the capital. They even bypass the available facilities in their small town, thinking that they are not going to get the best treatment. So they kept walking or traveling past a health facility, but the assumption is that there's nothing available there. And it will be 2 to 3 days before we get to see them in the tertiary referral hospital. The one critical question I want to ask Roberto, when this patient presented to the local area, what is the time frame? Did she present within the right time frame for thrombolysis and there is no thrombolysis available? Or were there any delay from the patient side? Like, did she present within few hours of the onset of chest pain to this health facility, or the delay is from the patient herself? This is very crucial in addressing the problem. Because in my country, the main problem, although the health facilities in that area would add insult to injury, but the Achilles we're getting is the patient presenting within the time frame that is required for the best treatment. So how long did she take before she present to that local facility?
Well, in this case, the difficulty was herself, because she's a nurse and she went to the place where she works, which is a big clinic. But according to my colleagues, she took 48 hours. After asking her, yes, according to my colleagues, the first doctors who saw her. But after I received her, after treating, and I did ask her, we could say like 30 to 28 hours on the biggest, the chest pain with the biggest intensity. And she works on that place, and that place is a good clinic with good facilities, but she works on that place. So she doesn't have any problem going there. And she's a nurse, she has a car, our emergency services are also an issue. But she didn't mention to me that first she called it emergency service. No, she mentioned to me she was waiting that the pain will go past. So the main thing on this patient was herself. She took a long time to take the decision to go to the hospital.
So let's move on to hear about the patient and the transfer of the patient, because I think that we all agree that ultimately the patient needs to get to a facility where there is a angiographic facility. So let's hear about the next steps. We'll hear the discussion between Roberto dos Santos and Isildo Dombele, who was a transferring physician.
Good afternoon. We are starting our sessions for Africa PCR. We are talking about with my colleague, Dr. Dombele. He was responsible for the transportation for a patient from one facility to our facility. So my first question to Dombele, how did you meet the patient? Como é que estava doente quando a encontraste? I could find the patient with blood pressure was hemodynamically, she was stable. It was only, we could see a bradycardia with 45 to 50 heart rate per minute, but she was stable even having with that bradycardia. Another question to you, Dombele, which type of transportation do you have? Which are the conditions do you have to transport this patient? Quais são as condições para o transporte habitualmente que tens para transportar esta doente?
Faço parte de uma instituição que tem as condições necessárias para um transporte de um paciente grave. Nós transportamos a paciente por intermédio de uma ambulância com UTI, uma ambulância com todos os recursos para o transporte de um paciente grave. Foi um transporte que durou aproximadamente 30 a 45 minutos e decorreu sem intercorrências. Ao longo do transporte, a paciente manteve-se estável do ponto de vista hemodinâmico, não teve necessidade de uso de oxigênio nem de outro tipo de suporte. Foi um transporte rápido e super controlado, sem nenhuma intercorrência.
Well, I work in an institution where we have ambulances very well prepared to transporting this type of patients. We have intensive care material, this type of facility. But to this patient, we just gave her slightly oxygen, but during the transportation, which took 30 to 40 minutes approximately, I cannot sure now, 30 to 40 minutes, was a transportation very comfortable, no other thing happening during the transportation. E quando chegaste à clínica, a doente foi entregue diretamente e foi referenciada logo para a unidade de hemodinâmica. Foi isso que aconteceu, não?
Certo. Já encontrei uma equipa preparada, a enfermeira da hemodinâmica, um médico interno de especialidade no banco de urgência, e receberam-me prontamente, fizemos a transferência da paciente, e a paciente foi encaminhada então para a hemodinâmica. Na altura, a paciente ainda mantinha um desconforto torácico ligeiro, o ECG da paciente ainda mantinha um supra de ST em parede inferior, mas a paciente mantinha-se estável e correu tudo bem.
Well, when we arrived, there was a nurse waiting for us, and a doctor. A doctor who works is doing fellowship in cardiology. They were waiting for us. The patient was continuing stable, but the ECG was having ST elevation on inferior leads. But the transportation was stable, and they received us, and we delivered the patient to them, and then she went directly to the cath lab. Queres acrescentar mais alguma coisa? Eu acho que estou satisfeito. The intention here was to describe how was the patient, how was the transportation duration, and I think I'm happy with the questions that my colleague answered. Muito obrigado, Isildo. Thank you.
Thank you for that description of the transfer of the patient. We will get to discuss some of the aspects of the transfer in a short while, but let's first hear from Roberto how he received the patient in his hospital, and then we'll hear from Awad what he would have done next.
I received the patient very, very, very stable. As we heard just before, the patient is 46 years old. Okay, she was a 46 years old female with risk factors of type 2 diabetes. So as my colleague described it here before, she said chest pain started from the 21st of April at 10 o'clock in the evening, and she went to emergency department after 24 hours. But the doctor who first spoke with the lady, nurse told me in the beginning, she said it was 48 hours. So the ECG was with having ST elevation in inferior leads and AV block. Total AV block. The blood pressure was 121/69, and the heart rate was 45. And this is the ECG that we have, that the colleagues brought with the patient. And while, well, this is not moving on, but I believe it will move on right now. Okay. In the emergency department, they did the diagnose, and troponin were not available over there, and they gave 300 milligrams of aspirin and 600 milligrams of clopidogrel and some heparin, and stayed with the patient during the night. During the night, she said the pain didn't increase of intensity. She told that was moderate intensity. And then on the next day, transferred to our clinic for coronary angiography. I received her. She was saying, "Look, doctor, I still have a little bit of pain. In let's say from 1 to 10, she was having 2. Scale from 1 to 10, she was having 2. So we did promptly the angiography. This is the left system. You can see it from here that the left descending the anterior artery, I don't see any lesions, critical lesions there. And I found a critical lesion in the circumflex in the proximal segment of the circumflex. We have there a lesion. And then the access for this angiography was by radial, right radial artery. And then this is the right coronary artery. And we see the critical lesion on the proximal segment, proximal middle segment. So after telling the patient, I told her, look, your problem, we saw which is your problem, and we need to treat. So the decision was to promptly treat this right coronary artery. And first, we wired it, and then first we used a semi-compliant euphoria balloon at 2.20 times 15. Then after that, my slides are not moving so well, but the result is this. And then after that, decided to put the stent. And the intervention, the procedure was very calm. The patient was always stable, no electrical instability, no hemodynamic instability. So the decision was to put a 3 versus 3 times 24 resolute onyx stent. And this is the final result. I was happy with this result. And then the patient went to the ward, to the intensive care unit for the next 12 hours. And the echo was showing inferior hypokinesia, but with preserved left ventricular ejection fraction. And then we decided I would like to share with you which, if you will do the same thing or you will not do the same thing. And this is what I did approach the patient. After that, she asked, doctor, how is my problem? I told her, look, part of your problem is solved, but you still have one artery that we have to decide what to do. That was that circumflex. We put the stent on the right coronary artery, and I send the patient to the intensive care for 12 hours, and then in the morning I transfer it to the ward. I don't know if all of you will have done the same thing or not.
Right, thank you very much, Roberto. So, Awad, you had, if you had this patient who presented at this time, transferred, would you have done the same? Would you have gone for immediate angiography, and would you have treated both lesions in one sitting or staged? Maybe you can tell us if you would have done the same thing or different.
Yes, I think the crucial thing we need to look at the beginning in my country, we have around 27 cath labs around the country. 25 of them are operational. Only 4 of them are outside the capital. So most of the cath labs are cluttered in one city in Khartoum. The 3 outside Khartoum are very busy. The crucial thing is treatment of STEMI in my country is 100% free for all comers in the governmental hospital. All you have to do is to have a heart attack and turn up to the governmental hospital. There is dedicated only cardiac hospital in my country. 4 of them, 3 of them have an emergency room 24 hours a day. When the patient comes to the one of those hospitals, it's a pharmaco-invasive strategy we're doing. We failed so far to have a good primary PCI program in my country. Although the cath lab is operational, the technician and the cardiologist are available doing around 10 to 15 procedures a day, but yet we cannot get a primary PCI program off the ground, mainly because like the patients who present within the golden hours that you really need to do a primary are very few. So if this patient presented, I would, rightly as Roberto did, she's stable, she's one lucky patient that the arteries are still open, but I would, the only different scenario would be is to treat post lesion at the same setting. If there is no financial constraints as in a public hospital in Sudan. All the stents, all the wires guide are free. Of course, what we get to in private hospital or when the patient is insured, some other type of insurance, 5% of the Sudanese patients are insured of the 43 million, then the financial decision comes into the treatment, then you have to stop short of complete revascularization at that particular point in time. But where I work in a SHAP hospital, is the treatment is free, and the other lesion in the circ seems to me like a straightforward lesion that I can do with minimal contrast, and although with the circ you never know, but it seems straightforward job. I would have treated both lesions in the same setting. Did I answer?
So Ahmed, yeah.
Yeah.
Ahmed, let's hear what the participants have asked, and please feel free to give us your thoughts on their questions as well.
Yes, we have a number of interesting remarks. First question is balloon pre-dilatation in this situation the best option, or should we go direct stenting? Also, somebody asked about temporary pacemaker as backup during the procedure since the patient is bradycardic. And
so what are your thoughts on those points, Ahmed? Let's hear what you think about them and how your environment would deal with those.
Yes, I mean, we generally pre-dilate unless there is a high thrombus load. So in this case, it seems that there is no large thrombus load. So I would pre-dilate, especially if there is a possible element of calcification, and then you may have to make sure that when you deploy your stent, it's fully optimized. So we generally pre-dilate unless there's high thrombus load or high risk of no reflow or slow reflow. As far as the temporary wire, I would keep it in hand, close by, but the patient is sinus bradycardia. I'll keep it in hand. We always keep atropine ready, and in case we have to give it during the procedure. So I would have done the same thing as the scientists have done in this situation. One more question is, what do you think of the distal RCA? Another question, the distal RCA, do you think is significant? Anything needs to be done regarding that lesion?
Perhaps I can comment on those things from my environment as well. I think that pacing one should try and avoid if at all possible, because don't forget you could have right ventricular infarction as well, and the risk of RV perforation with a temporary lead. Personally, I would have favored direct stenting, to have the least amount of instrumentation in the STEMI setting. But I think it's interesting to hear all of these perspectives from the different operators. Roberto, you wanted to comment?
Yes. Starting from in this, we are working in the private clinic, but the majority of the patients that come here, they don't pay from the pocket. Either the insurance, either the company pays for the medical treatment. So this patient, she didn't pay anything for her pocket, and it was like an insurance because of the work. And but the money issue is there. It's a point, and sometimes it's very expensive for a person this type of treatment in private clinic. Also, we have in Angola we have four to five cath labs, but now running that two 24 almost 24 hours working, not every day, but there are two, but used to be 4 to 5 cath labs. Here the issue, the patient, I sorry that I didn't show the others ECG, but she was having a complete AV block, but the QRS was not wide. So I also decided not to put a temporary wire because of what's already said. And the other issue that I didn't mention here is, yes, I decided my decision of not treating at the same time was also because I didn't have the proper stance for the other lesions. Sometimes is the issue here. In my country, don't have everything that you need. But at that time, I didn't have the proper stent and for the lesion of the circumflex. I waited, but I will receive that after. But sometimes it happens. We don't have everything that we want at the moment, and sometimes we have to make some difficult decisions. But in this setting, I decided to predilate it first because also I didn't see a lot of thrombus burden there, and I was not sure about the size of the stent that I will use if I didn't dilate that before. So my option was that.
So to deal with the question that was raised about the distal RCA, I think it's an interesting one. The problem is that it's sometimes very difficult to assess the distal vessel without adequate flow. And since that's the one advantage of coming back to do the circumflex is you have the opportunity to see what the distal RCA looks like after some having established flow. So if you do have a problem with your first vessel, maybe that's an argument for staging like you did so that you can assess whether you really need to do something distally.
It is true. I didn't go and see again the distal right coronary artery. I classify that as a moderate lesion, not a critical one. And in the future, I'm planning to do a stress test and see how the patient reacts. But at the present, I didn't put anything on the distal part of the right coronary artery.
So Ahmed, any further points from the participants?
I think there's a bit of a discussion here of the timing of the left circumflex. I think you kind of answered a few of those concerns, whether we do the same procedure, index procedure with index admission. And I think it's also reasonable to talk about soon after discharge. I think the evidence is still inconclusive when is the best timing. Shall we do it during the index procedure or within the index hospitalization, maybe soon afterwards? I think a lot of logistics go in there. And DeSantis talked about challenge we face all the time. Inventory may not be available for every legion. I want also allude to the point of who's going to pay. The patient is paying out of pocket. Maybe sometimes we are inclined to do it during the index procedure so the patient doesn't have to pay again for coming to the cath lab again. And how bad is your list that day? I think there is a decision making, especially in our setting, besides the evidence that we hear from trials coming from elsewhere. And all of us, in a way, have to align their practice the best way they can to evidence-based medicine, taking into consideration local resources from inventory to available slots in your cath lab and everything.
I think you make a very good point, and it shows how the trials don't deal with these regional differences, and And it's important that you make the point that we need to do the job properly. So it may be better to stage and do the job properly with the correct products if you have inventory issues, rather than try and force the issue using the inappropriate tools.
That was my opinion when we work in our settings, but we have very big difficulties with material, and sometimes we work alone. We try more to do what is the best for our patient, and that was my mainly that I did it on the index hospitalization, but not on this moment, but on this hospitalization, because I knew it also that I'll get proper stent just after 2-3 days. I will show you.
You had the ICU ambulance transport this patient, Roberto. Is that the routine that you have a number of such equipped ambulances in your environment, or how do patients get transported to facilities?
This patient, she was locked. The decision of ICU transportation ambulance for this patient was made by the other hospital. Because she was in the intensive care unit and without cardiologists, and the intensive care unit doctor decided that she needed to be transported, and that doctor is the head now of the department of the transportation of patients. So it's not common for us that type of decision for the patients to be transported in ICU intensive care unit ambulance. No, it's very rare. But sometimes it does happen when we don't have the patients are in a big clinic like Clínica Girassol and Clínica Sagrada Esperança, and they are transported into other environments. Yes, but normally it's not the type of transportation that we use for transferring these type of patients in the majority of our hospitals.
So, Awad, when you give patients a lytic in a peripheral hospital and then transfer them, what type of transport is typically used to transport them?
I'm afraid to say the situation of the ambulance service in my country is appalling. It's synonymous with the third world, low limited resources facilities. Most patients come on their own, private transportation. And when they have to have an ambulance, the ambulance, all you're getting in that ambulance is the sarin and oxygen. Maybe you get oxygen. The driver is a merely driver, so no medical background, so he won't bail you out if anything happens to this patient. So you get the patient's relatives and a car with a sarin that can get you fast to the hospital. That is all you're getting. So I think we need to work on that. There is no trained personnel in the ambulance, no ECGs, no facilities of transferring. So it's mainly a car that can get you there fast if you get there at all. So most of the patients, they are using their own private cars to be transferred around facilities for them.
Yeah, that's very interesting. Ahmed, further points from our participants?
Yes, I think one question is about the LCX. Is the angio conclusive enough? Who would be using pressure wire FFR to decide about the LCX, or the availability of FFR in your lab as to decide whether non-corporate disease is worth of stenting? I'll leave that to Awad and DeSantos, maybe give insights on how they decide on non-corporate disease in STEMI patients.
Okay, Roberto, you go first.
I'm not so lucky as you are, so I don't have any FFR, any IVUS. I don't have any functionality testing in my cath lab. So we are trying to have that. And even for ischemia studying the patient, when we want to study, like when we do the case and the lesion doesn't appear as very critical to treat, the only ischemia testing that we have is stress test. I've been asking my colleagues to do stress echo, but until now I do not have stress echocardiogram. So I only have stress test. So the decisions is a little bit more tight, and sometimes maybe not most correct decision, but we don't have all those tools like to study ischemia. So the decision has to be made by like critical or not critical. But sometimes we need those tools, and they're very useful to do and to perform very better our procedures. But we don't have them here in Angola.
Awad, in 30 seconds, you can just describe your situation, please.
I wouldn't consider pressure wire here. Like this lady is lucky to have got away with it, delayed presentation. Her artery was already open at the time you took her to the cath lab. The lesion, I'm sure I would have known the artery is open. The missing piece is the ECG just before the cath, because surely this ST segment elevation has already gone by the time she went to the cath lab, as evident by the flow. The lesion in the circ, to me, looks significant. The lady has already had a hypokinetic inferior wall. She has no pain now, all right, but she survived an inferior myocardial infarction, and that circ is there looking at me. I would have stented it the same way he did without pressure wire. It's financial decision we had to make in this part of the world, and I wouldn't use a pressure wire.
So, thank you. I think what we've heard today is interesting commonalities as well as regional differences. You know, Africa is a vast continent with vast distances between facilities and infrastructure and lots of obstacles to patients getting to treatment. Lack of education and lack of patient awareness we've heard about. We've heard about limited facilities, lack of lytics available, and the challenges that we have with inventory once they get to the referral hospital. So I think the objective of these webinars is to try and raise these issues and try and improve our systems of care in STEMI. And I know that you, Roberto, and Awad are actually working together on a program to create awareness of STEMI in Africa. And congratulations on that. And this webinar just highlights how important that work that you're doing is. So please keep it up. And I hope all the participants enjoyed the webinar and can think about how they can make changes in their environment to try and improve access to care for our STEMI patients. Perhaps I'll just finish with showing you what the remaining webinars are in this series.
Audrey, if you can, the final result of the circ.
Yeah, we will. Let me just mention these webinars. We have a webinar on these dates: pregnant woman with mitral stenosis, Nigeria and Uganda, patient with chest pain and dyspnea from Mauritania and Tunisia, and a patient with a pacing challenge from Egypt and Kenya. We'll end off showing the final picture of the circumflex, and with that pretty picture from Roberto, we will say goodbye and thank you very much to all the colleagues for their contributions and for your attendance.
Thank you very much.
And well done to all of you, and thank you very much for your attention on this webinar, and please attend the other webinars. Good afternoon and good evening, everybody.
Bye-bye. Thank you.